Good afternoon, everyone. My name is Deanna Fenton, Program Manager here at the Alliance, and I'd like to welcome you to today's webinar entitled, Why Does Social Support Matter for Transplant? We're so pleased that you could all join us as we have a wonderful presentation in store for you today. Now, before we begin today's presentation, there are just a few housekeeping items that I'd like to review. For optimal visual and audio experience, these webinars are best accessed in the Chrome browser. If at any point you encounter any audio issues, we recommend logging back in using Chrome. If you continue to experience these audio issues, please dial in using the phone number provided in your confirmation email. Now, for those of you who have never joined us on this webinar platform before, please take note of the chat feature that is located in the bottom left-hand corner of your screen. This chat can be used to pose your questions to our speakers. If you have any questions that come up during the webinar, please feel free to submit them at any time. Once the presentation is complete, we'll have some time for our presenters to address as many of your questions as time allows. Now, for those of you who may be interested in our upcoming webinars, registration is currently open for our next webinar entitled Anatomy of a Donation Champion. That's coming your way on May 14th at 2 p.m. Eastern. Registration is also open for our upcoming webinar entitled Confronting Stigma, the Impact of Substance Use on Organ Transplantation. You can register for all of these webinars and more on our website at organdonationalliance.org. Now, for anyone seeking continuing education credits, please note we are offering one SEPSI credit and one nursing contact hour for this webinar. Everyone joining us today is entitled to claim these credits. If you are listening in a group, as many of you are, please make sure to get the evaluation email from your group lead. There's a very brief online evaluation which will allow you to receive your credit. Just as a friendly reminder, for nursing you have 14 days to claim your credits, and for SEPSIs you have 30 calendar days. Now, at this point in time, I'd like to introduce our moderator, Sunmi Ju, Clinical Social Worker at Barnes-Jewish Hospital. Sunmi, thank you so much for joining us today, and at this point, I'll turn it over to you to introduce our speakers.
Thank you. Good afternoon and welcome, everyone. I just want to say before we even begin that we are very lucky and fortunate to have such a great group of professionals with skills and experience for this webinar. I'm introducing now. Our first speaker is Rebecca Basson. She received her master's degree in social work from Washington University in St. Louis. She has worked in medical social worker with chronic illness for her professional career, currently serving as a clinical social worker for the lung transplant program at Barnes-Jewish Hospital and Washington University School of Medicine. Rebecca serves as the co-chair for Barnes-Jewish Hospital's Ethical Consult Committee and is a lead for the consult service. She completed the ethics practicum in 2015 and has been a clinical social worker at Barnes-Jewish Hospital for 19 years. Our second speaker is Kay Kendall. Kay has worked as a transplant social worker for 30 years. She has published articles, a book chapters about transplant, the psychosocial assessment, and quality of life pre and post-transplant. She has presented at both national and international conferences about psychosocial aspects of heart transplant and mechanical circulatory support. She was recently one of the 6 leaders involved with the publication of the ISHLT consensus document. She has been a member of the Society for Transplant Social Workers for 25 years and has served as a board member for 23 years of those years. Our last speaker is Blair Sostrom. She received her master's degree in social work with a concentration on health and mental health and specialization in gerontology from St. Louis University. She completed her graduate school practicum at Barnes-Jewish Hospital on the lung transplant service. She moved to Memphis and began working for the organization as a family care coordinator, offering families the option of organ and tissue donation at the time of their loved one's death, as well as providing education and hospital development promoting donations within hospitals in Mid-South. She is a licensed master social worker in Tennessee and a member of the Society of Transplant Social Workers. Blair currently works as a transplant social worker with kidney, pancreas, and liver transplant recipients for Methodist University Hospital Transplant Institute in Memphis. Please join me in welcoming our speakers today. Kay?
Thank you. I'm really also very pleased to be able to participate in this webinar, and I'm going to begin by presenting information about research that has been conducted in the area of social support for transplant patients. First, I think it's important to understand a good definition of social support. It is the perception and actuality that one is cared for, has assistance available from other people, and most popularly, that it is one part of a supportive social network. Social support refers to the various types of support or assistance, often referred to as emotional, informational, and instrumental. And some articles break these categories down further and add affective and positive support. Next slide, please. But most consistently, we refer to supports as really instrumental or practical and emotional support. Next slide, please. So why do we want to know about social support? Social support is important to have an understanding of how it impacts individuals through the phases of transplant. We also need to have a good understanding of support systems as we look at the significance of support systems in the transplant decision-making process. From the early 1980s, and really even before that, when we began doing psychosocial assessments with transplant patients, available supports has been a domain of the psychosocial evaluation. This support, looking at support system, has been as relevant of a factor in the evaluation as mental health history, substance, alcohol, nicotine use, and compliance. I began with our program 30 years ago, and I look back at some of my earlier assessments, and the format may have changed some, but I am still gathering the same group of information that I did in 1989. Research efforts to determine how psychosocial factors impact quality of life and, importantly, morbidity and mortality began several decades ago. One of the challenges for me in trying to condense so much research that has been done about support systems for transplant patients was just that. How do I possibly condense that? So I have chosen some key articles, I think, that will be helpful to mention. Very importantly, if you have never read any of the articles published in the 80s and 90s by James Levinson and Mary Ellen Olbrich, I really encourage you to do that. They were pioneers in psychosocial research. They were at the University of Virginia, and they conducted many landmark studies in the 80s and in the early 90s. Importantly also, these two individuals developed the PACT scale, and I'm going to mention that in a moment when I talk about an article, a research article. And the PACT scale is the psychosocial assessment of candidates for transplant. But in the late 80s, early 90s, these individuals certainly sensed that there was a great deal of variability from organ system to organ system and program to program about how programs looked at risk factors, psychosocial risk factors. They sent out a survey to different transplant programs in the United States and had programs rate what they would consider as either absolute, relative contraindications or not a factor in the decision-making process. They were looking for a common ground, and as we still experience today, there may not be a lot of common ground as we look at from program to program. But consistently, absolute contraindications that were mentioned in their study were active schizophrenia, current suicidal ideation, and dementia. Social support was seen by most programs as a relative contraindication. In 2013, Conway published a really very excellent article, and it was a review of both psychosocial and physical health factors. One of the most prominent findings in this paper was that having adequate support from a variety of sources was considered to be essential through the transplant experience. The importance of social support did not seem to be culturally specific. In this article, there are several research publications of Dr. Mary Amanda Dew, and I'm going to mention Dr. Dew a little bit more later. And a couple of these articles are summarized. Recipients with lower social supports are at increased cumulative risk for psychological disorders, and social support is an important contributor to the long-term post-transplant health. In 2016, Hitchfield and a group published a study using the PAC scale as a rating of psychosocial factors with 110 patients, and they were followed for an extended period of time. The PAC scale rates support systems by their stability, availability, and commitment of relationships. This study showed that greater psychosocial risk was associated with post-transplant mortality for over the 12 years that they were monitored. And very interestingly, at any time after lung transplant, the group with higher psychosocial risks were at 2.7 times greater risk of death than those with fewer psychosocial risks. Another study done by Malberg in 2015, again looking at long-term outcomes with lung transplant patients, stated in this article that social support is acknowledged as being essential for postoperative follow-up care, and the absence of a consistent or reliable social support system is recognized as an absolute contraindication to lung transplant. In the early work by Levinson and Olbrich that I mentioned, and really additional articles that have been published since then, thoracic transplant programs, heart and lung transplant programs, consistently seem to have the most stringent, strict criteria for listing patients. And another interesting note in this study was that more and more as our healthcare system is changing, family members are being called upon to cover gaps in healthcare services. And a point that he mentions also, that those individuals cared for by a spouse had a higher survival rating than patients cared for by a sibling or an adult child. In 2012, Dr. Jose Maldonado published an article that presented the SIPAT, the Stanford Integrated Psychosocial Assessment Tool. Rebecca is going to talk about this more in her presentation, so I'm just going to mention a couple of things quickly. It published a second article in 2015 where he had followed 217 patients that had been rated with the SIPAT scale for 1 year. I wanted to add to today many transplant programs use this SIPAT tool as a way of rating psychosocial risk factors. In his study, he found that SIPAT scores were correlated with higher rate of rejection episodes, medical hospitalizations, infection rates, psychiatric complications, and failure of support system. The SIPAT rates the availability of support, the functionality of support, and the appropriateness of living space. I want to take a moment to talk a little bit about the ISHLT Consensus Project. This is the International Society for Heart and Lung Transplant. This project began in about 2015. I'm sorry, we're on wrong slides. If you can go back to that, thank you. This project began in 2015, and the article was published in 2018. I was extremely honored and privileged to be a part of the leadership group on this project and led a work group. The focus of our committee was to develop a synthesis of expert opinion on the content of the psychosocial assessment, the processes and procedures, and also to have a comprehensive literature review of empirical evidence to support the committee's recommendations regarding the evaluation content and process. If you look at nothing else in this article, There are over 200 references cited, and it is a wonderful resource for articles about psychosocial factors. The aim of these recommendations were to help programs in constructing evaluation protocols that comprehensively gather information on psychosocial factors. Social support was one of the components or domains. It again looked at support regarding the availability, stability, and capacity, the understanding of options and care needs of a support person, and expectations about post-op care needs. In our paper, it is stated that the lack of sufficient social support is a contraindication to cardiothoracic transplantation and also mechanical circulatory support implantation. The psychosocial evaluation should ascertain the availability, stability, and capacity of patients' support resources. Evidence that we reviewed about support systems: better social support predicts better behavioral, psychological, and clinical outcomes in cardiothoracic and other solid organ transplant recipients. And again, there should be another zero there. Over 200 references are cited. Poor social support is associated with non-adherence, substance use relapse, and higher 30-day readmission rates for mechanical support patients. Importantly also, the evidence talked about that strong social support can mitigate the impact of certain risk factors, cognitive impairments, and mental health problems. The final article I want to talk about was written and published in 2018 by Karen Ladin. The article, How Important is Social Support in Determining Patient Suitability for Transplant, has been discussed by a number of my social work colleagues. In 2016, a survey was sent out to Society for Transplant Social Work members and the American Society of Transplant Surgeons. 627 clinicians did respond, and the respondents were presented with questions comparing two hypothetical transplant candidates. The results of this study: most providers reported having used the profile of a patient's support system when making listing decisions. Most providers perceived social support was important for preventing organ waste. And importantly, a candidate life expectancy with transplant, adherence to medical regimen, and social support were the most influential factors in transplant decision-making. Psychosocial providers were more likely to select a candidate with social support. Medical surgical providers were most influenced by candidates' life expectancy. There were some very important barriers identified in this article. Ladin spoke of a lack of clarity regarding how to evaluate social support. I go back to our ISHLT paper, and a section of that paper, a piece of that is about the process and procedure of conducting an evaluation, and that is very helpful in also learning how to gather information about social support. Barriers vulnerable populations face in listing for transplant is discussed in this article. And certain groups of patients, patients in rural areas, those of certain socioeconomic status, may face greater difficulty demonstrating social support. Both in the SciPat article and also in the ISHLT consensus paper, it is emphasized the importance of identifying risk factors. But both of these papers, and certainly many other publications, emphasize the responsibility of clinicians to work with patients to attempt to reduce or ameliorate these risk factors. And these barriers that are mentioned, that again is one of our great responsibilities to try to help individuals overcome these barriers. In summary, we know that social support is important for the transplant patient through all the phases of transplant, and we know through decades of research that having a reliable, helpful, and available support system impacts transplant outcome.
Thanks, Kay, for laying the foundation for our talk today regarding the literature and what we've been seeing throughout the years in doing transplant. I want you as a participant to just take a minute and think about how caregiver issues manifest in all of the different programs that we work in. Think of the differences between solid organ versus bone marrow transplant, the differences in kidney versus heart, even the differences between one lung transplant program to the next transplant program. As a social worker, I'm having trouble, Deanna, going through the slides, moving forward. There we go. I think about all the caregivers that I have in my life. As a young practitioner with small children, I often joked with my colleagues that I needed a husband or that I needed a wife because there were always things to do, always errands to run, and that was always so much more difficult when you were working full-time. But I remember very distinctly early in my career working with a young patient from Nebraska, and she and her husband back in those days moved here before transplant. That was when lung transplant recipients had to accumulate waiting days. And this husband really struggled with getting and receiving help. That was just not something that he had been used to. They were a young couple. They had adolescent children. And I remember distinctly one day when they were at support group, and he finally said in front of this group, I realized that I have become the vessel for which people can do good. And that has resonated with me for many, many years, just thinking about and telling patients it's not just about you, but it's also letting other people in your life feel good about the help that they're offering to you. I think we also have to talk about the role reversal. We have to talk with our patients about how husbands and wives can become patients and caregivers, how sons and mothers then become patient and caregiver, and then after transplant, how those roles can reverse. And Blair's going to go into a little bit more detail about what those roles mean. I think it's also kind of funny that we think about the caregivers we have in both our work and in our play. There's a joke here now that I am kind of considered my colleague's work mom, and that just makes me feel old because it seems like yesterday I was the work sister of many of these young people. The next one just kind of talks a little bit about some of the Center for Medicare and Medicaid Services operations manual specs. I think over the years we've seen these guidelines and these regulations be very vague. They do reference caregiver support, social support, and its role in transplant, but not specifically in defining the role or screening for those individuals. But it's always quite comical to me when we get site visits by CMS and they'll come in and talk about something very specific. I remember one year when they audited our LVAD program when we were getting certified as a Center for Excellence and cited us for not noting in our psychosocial assessments that people had 4-prong outlets for their LVADs in their homes. Just continuing a little bit with that, they do recognize the flexibility that transplant programs have in doing psychosocial assessments and the various tools that we use. We as clinicians know that our role is to look at those situations as a strengths-based perspective and to really help them pull from their own life experience and how they can make this a success. I noted just the other day that we've had a woman waiting for transplant for 14 months. She lives in Arkansas, and we actually had to put her on hold because her support, her husband, her only support, now has to have back surgery. So her entire journey in transplant has been halted. On the next slide, we just kind of continue this discussion from CMS, and it talks about the role of caregiver support in discharge planning. And I think all of us as clinicians may disagree with the fact that discharge planning begins the day of admission, but we really see that as the day that they walk in our doors and we start to talk to them about this process. So our job as clinicians is to look and see who comes to the evaluation, who comes to clinic, and who's at the bedside during that process. And then lastly, in the CMS specs, if you look at bullet point number 5, and we talk about a plan for addressing psychosocial issues, again, very vague, but using the term available support. And we're going to talk today about how to address this need and what really are the responsibilities of the caregiver. So think about Joe. Joe was diagnosed with pulmonary fibrosis, and he was evaluated at our program. After waiting 69 days, he got a transplant. He's had a pretty normal post-op course, but we noted that he was a little sluggish with his rehab. We figured it was just because of his age. But at the day of discharge, he was walking 22 minutes on the treadmill. So we sent him home. He was scheduled to come to pulmonary rehab the next day at 10 o'clock, and his adult daughter was his support person. His wife had to continue to work to maintain the household income and the health insurance. So Joe got up for pulmonary rehab. His daughter went to his room to get him. He stood up, dropped to his knees, and went into a respiratory arrest. She started CPR, but unfortunately Joe died after EMS arrived. Of course, it's a very sad story, but it raises the point in the debate about whether patients need or do not need a caregiver during this journey that they take. As with Kay, I've been doing this for quite a while, and I know over the years I've always taken the assumption not to believe that I know who they're bringing with them to their psychosocial assessment. We all know that wives could be sisters, children could be spouses, girlfriends may really be the Uber driver, and spouses in some bad situations could be abusive. So as clinicians, we have to really dive into assessing the individuals that come through our doors. One of my very favorite questions to ask patients is, if you went to the gas station and bought a scratch-off ticket and you won $4 million in the lottery, who's the first person that you would ask, that you would call? And to kind of explore that relationship with that person and how the patient perceives them having a role in their transplant journey. That assessment really addresses, is that individual an adult? Are they available to take care of and be present 24 hours a day, 7 days a week? And if not, who's going to provide respite to them? Is that individual able to follow directions, changing the dose of medication, finding a clinic appointment in the middle of the day, or going to a new location for a follow-up test that they've not been to? And are they able to drive? Can they get back and forth from where they're staying locally or home to medical appointments? And if they're not able to, are they using a hospital shuttle, and then also considering the need for other types of transportation, such as groceries and pharmacies? Kind of moving on, in assessing for caregivers, it's important to address educational needs. We all kind of consider issues surrounding literacy and what are patients' strengths, but how do we as practitioners avoid passing judgment, but rather designing education programs and messages that fit their needs? I think we could probably talk half an hour about Family Medical Leave Act, because so many times patients and caregivers come in the door thinking that they're going to get 3 months of paid leave. And our job is to provide them education and the distinction between the fact that FMLA is really job protection under certain parameters, and it's not necessarily paid. So I like to tease that out a little bit and talk about what is intermittent versus continuous leave. Ask those caregivers, what are you going to do if you're without income during those 3 months? And specifically, if that means you're without income, how is that health insurance that you're getting through that employer being paid? One of the key questions that I like to ask a lot of my folks or caregivers that want to come into this role is, can your coworkers donate paid time to you? And various employers will make that a benefit during a rough time like this. There's some really good handouts online for consumers of FMLA, so I encourage you as clinicians to have those available to your caregivers who are considering this, so that they know that they have rights and parameters with time frames. Another question that I like to ask is, who do caregivers take care of at home besides the patient? Is there an elderly mom? Is there a disabled sibling? or is there just a plain old kind of old pet that might need a little TLC when that caregiver is in town taking care of a patient? Moving on a little bit, Kay talked about the use of the SIPAT, which is the Stanford Integrated Psychosocial Assessment for transplant. I'm sure many of you as social workers are using this scale when you're doing psychosocial evaluations on patients being considered for transplantation. And really its intended use is to score and rate the suitability of patients as psychosocial candidates. And specifically, it talks about rating the functionality of a support system. So it ranks that between 0 points for excellent to a high score of 8 for people that really don't have or need to effectively work to find reliable support, or they have support that maybe isn't working well with the transplant team. I just want to present a couple of quick scenarios. I know we're a little ahead of or behind time, but just think about Carol. She's a 45-year-old with end-stage heart disease. She presents with her 71-year-old mother, and she fears that her mother is going to be her primary support person. Although her mom doesn't drive, she's independent with her ADLs and is financially secure. So think about how you would rate Carol's caregiver, and I think most of us would look at her as being excellent to good. She's showing up to the appointment. She's engaged in the care. She's probably explored the role with her daughter. We'll move on and skip the second scenario, as I know we're running a little bit out of time, but I want to skip to just a little survey I did looking at other programs' requirements. I talked to the lung transplant social worker at Cleveland Clinic. Their caregiver requirements are that they have 1 primary, and that's just 3 backup. Pretty typical. They have to be over 21. They have to be sober. But what is also relevant is if they are the driver, they have to be able to navigate a large city. And when you think about some of the patients that come from rural areas or other states where they're not around a major metropolitan area, it certainly can be a big challenge for many. Here at Barnes-Jewish Hospital in our liver program, if we have patients that are traveling more than 2 hours from the hospital, they have to stay in the area for 2 to 4 weeks and have a 24-hour-a-day, 7-day-a-week caregiver. When they go home, they also have to have somebody with them 24 hours a day. That caregiver has to have a valid driver's license. They have to be around when the patient needs care, and they have to understand the post-transplant education. What was kind of interesting with my bone marrow transplant colleague, kind of the same requirements as far as caregiver, but what we noted with discussions with Hope Lodge and some insurance programs was that their requirements of caregivers were much stronger than some of the parameters that hospitals set. So some things for us to kind of reconsider. Blair, I'm going to turn it over to you.
Thank you, Rebecca. So I have the privilege of talking to you about the ways that a caregiver can support a patient through all of the phases of transplant. Before discussing that, I think just the why is so important to review, why both short-term and long-term support is so important. So here, I'm referencing here a study that was done in Brooklyn, New York. It investigated the relationships between social support, the patient's attitude towards the transplant, and feelings of powerlessness in randomly selected long-term post-kidney recipients. So to keep it brief, they used a Likert scale-based questionnaire, and the study showed that patients who had strong social support were less likely to feel overwhelmed or out of control, and they had a better understanding of their transplant medications and overall transplant experience. It also showed that even in long-term recipients, feelings of anger and anxiety were persistent and worse in those who had poor social support. So because adherence has been associated with the recipient's attitude towards the transplant, it's so important for us to continually assess support, not just during the first few months, but as the patient, and here in this study, the kidney, but in general, as the patient and the organ age. So long-term support really translates to better outcomes. So I'm going to discuss some different ways that a caregiver can support a transplant patient during all phases of the transplant. So these are the points I'm going to discuss in detail, but from a high level, a caregiver can be a second set of eyes and ears for the patient. They can lend a helping hand physically, they can be an advocate, and they can provide emotional support. So let's jump right into my first point here. This starts with the very first appointment. Caregivers should get involved from the beginning. They should be accompanying the patient to the education class. At most centers, it's a requirement that a patient brings someone with them because it's difficult for a patient who is ill to sit through maybe a day of testing or sit through a class for a couple of hours and retain all of this important information to go home and share with their caregiver. So a caregiver should be there to take notes and listen to all of that information as well. They should also attend most, if not all, appointments during the evaluation. That way they're meeting the transplant team members and attending, of course, the post visits as well. So that way the caregiver is gathering information and an understanding of what this experience will be like and what will be needed for them on the post side. Learning medication names, doses, and uses. There are obviously different side effects and certainly an increased amount of new medications in addition to some or all of their previous medications. So that is overwhelming for a patient who's recovering to manage on their own. So a caregiver can help learn this new regimen. Maybe it's picking up the medications from the pharmacy, setting up a pill box or a system. It's very helpful. Organizing appointments and follow-up and overall just a new schedule. The workup phase includes many tests and appointments, we know, but the patient may have an LVAD, they may be on dialysis, they may be getting regular paracentesis, so it can be overwhelming to them to manage this new schedule on their own that's different from what they've previously been doing. Another important duty of a caregiver is recognizing when to call the nurse for symptom management or general questions versus recognizing when they need to act quickly. If the patient is short of breath, when they need to call 911 versus calling their nurse coordinator. And what information is important for them to report, speaking maybe to the medications the patient's on, their most recent dose that they took, and things like that. A helping hand, just general responsibilities here, overseeing discharge instructions. Maybe it's medical equipment being delivered, maybe it's a home infusion being set up. But a caregiver can alleviate some of that stress and fear of leaving the hospital staff and leaving those great hospital caregivers and going home knowing that this will be taken care of. So assisting with ADLs, and that, of course, depends on the organ in some ways, but most patients, they just need a little help with meals and chores around the house and even just encouraging the patient to get up out of bed, move, take a walk, things like that. Driving or arranging transportation at least for 6 weeks, sometimes longer, depending on the course. Sometimes I joke that a caregiver wears many hats, and one of those is a chauffeur because those initial weeks post-transplant are the most critical that we as transplant professionals are laying eyes on the patient and ensuring that organ's functioning properly. So we need them to be able to get here with no problem. In some situations, maybe the caregiver is setting up Medicaid transportation or another service for the patient, and that's fine too, whatever it takes to get them here. Carrying anything over 5 pounds with certain organ groups, there are restrictions, and that can be limiting for the patient at home if they don't have help with that. Patients often underestimate the amount of help they will need. A lot of times I hear a lot of just, I'm an independent person. I've been on my own a long time. I'm going to be fine. I don't need much support. And it's our job as transplant team members to ensure the patient and caregiver understand that this is different. This is a major surgery. There's going to be pain. There will be a long list of new medications to manage, lots of appointments. It's a lifestyle change even without complications. So throw in readmissions or rejection episode while we hope to avoid those things. Those bumps in the road really intensify the need for support, and no one can go through this on their own. So the patient has to be willing to ask for help and accept it. So I try to mentally prepare my patients to be open to that from the beginning. A caregiver can be an advocate in many ways. They can speak up if they notice the patient's needs are not being met or if they're struggling in some way. Once they're discharged, we're not laying eyes on them quite as much, so that's where the caregiver can really step in if a patient's not willing to ask for help or clarification about something. Fundraising, and this can require a small amount of effort. It doesn't have to be a giant movement within the community. But the patient is sick and they may not have that extra effort to spare, but are still very much in need of funds to assist. So it's a great way for those with bigger families or support circles, even out of state, to get involved. The National Foundation for Transplant, a wonderful organization. We give their information to our patients while they're in workup so that they can begin to discuss that with their families. CODA is another great resource for our pediatric patients who have families who desire to fundraise or set up a team to do that. The caregiver can be or help to identify a live donor champion. Most of us are familiar with this program. It was developed by Johns Hopkins Transplant Program, but by definition, a live donor champion is a person who receives special education by the donor team. So they're taught about the whole donation and transplant process, how to use social media in regards to looking for a donor. They're given materials and tools to help find a potential living donor for their family member or friend. So this is great for kidney and liver patients seeking a live donor. The caregiver or the champion can make, I've seen business cards, flyers, sharing their story through churches, local businesses, and other groups within the community. One quick example that comes to mind, we had a patient whose family member had a decal made for their vehicle. It had the patient's name. I think it even had a picture of the patient, what organ they needed, the blood type, the transplant coordinator's name and number, and they put it on the back of their family member's vehicle. So it was driven all around the city, which is just awesome. So many people saw that. It's one creative way to help find a donor. These types of ideas are great, particularly with kidney, because the wait time can be so long. I checked this morning. I think it was just over 95,000 people on the waiting list for a kidney per UNOS this morning. So the wait times are growing, and it can be very disheartening for the patient who's just been put on the list for a kidney to hear those stats. And knowing that someone is trying to raise awareness on transplant and donation, whether it's fundraising or in the community, educating, looking for a living donor, it provides them with hope and encouragement while they wait on the list. So emotional support, to me, this is one of the most important duties of a caregiver. Not to make light of it here with my cartoon, I just thought that was cute. It's the Transplant Organ Support Group, and he lives in constant fear of rejection. A caregiver can talk with the patient about their experience. Every patient feels differently, of course, but many times they've been faced with a real fear of dying while they're waiting on the list. And caregiver support helps to validate the trauma of what they've been through, especially if it was an emergent workup and the patient didn't really have time to process exactly what was happening. That can be traumatic. A caregiver is someone to confide in if the patient is feeling guilty or unworthy of the new organ. Buyer's remorse, that's a term I've heard from recipients in the past shortly after they receive the transplant, where they begin questioning if they should have done this. Are they worthy of receiving this gift? What am I going to do with it? Of course, we as social workers are available to discuss those thoughts and feelings, and we should be consulted if a patient is struggling, but sometimes it just makes a difference when this validation comes from the caregiver who is at the bedside the entire time and was with them from point A to Z. The patient may have made some major changes in order to become a candidate for transplant. For example, maybe they stopped smoking or they've been remaining abstinent from substances for an extended period of time. So having strong caregiver support can help to prevent relapse post-transplant due to feeling overwhelmed. Also speaking to lifestyle changes, the patient may be faced with a new role. Maybe they're returning to work after months or even years of being on disability and being unable to work. So that can be scary in and of itself to get back into the professional community if you don't have a lot of contacts anymore. It's been so long since you've even thought about that. Changes such as the need for strict hygiene rules, maybe it's a special diet in some cases, and adherence with the post-transplant regimen, it's intimidating to many of our patients. So these changes can seem less scary to the patient if they have strong caregiver support at home. This is one reason why our transplant support group is so special to me, and it's so important for pre- and post-transplant patients, in my opinion. It's a great way to connect with others feeling the same way or who've had similar experiences. It's also a great way for caregivers to connect with other caregivers because they need support too. We sometimes put them on the back burner, but we need to encourage our caregivers and make sure their needs are being met as well so that in the long run, our patient is taken care of. So just a recap. The caregiver can be a second set of eyes and ears. They can lend a helping hand, advocate for the patient, provide emotional support, and ultimately they can make a huge difference in the transplant outcome and experience.
All right. Thank you so much, Kay, Rebecca, and Blair, for such an informative presentation. Before I turn it back to Sunmi for questions, I'd just like to remind everyone, if you do have any questions for our presenters, please be sure to submit them using the chat feature. Again, that's located at the bottom left-hand corner of your screen. Also, during the Q&A session, I will have this poll up. So for those of you who are listening in a group, if you could please just complete this poll to let us know how many people are actually in your group, that would be greatly appreciated. Thank you. And at this point, I'll turn it back to Sunmi to moderate your questions.
All right. While we're waiting to audience typing their questions, I have some questions. Kay, how can clinicians encourage social support but also reinforce patients' independence with care?
Well, you know, it was so interesting as I always so appreciate and learn so much from hearing my colleagues, and it's a tricky balance, I think, because we talk about and so emphasize the importance of social support and 100% believe in that, but how do we also encourage a patient to be the one that is knowledgeable about medications? For our heart transplant patients, we don't discharge them from the hospital until those patients show 100% independence with sorting medications, knowing the names of them. We want that support person and caregiver to be knowledgeable and involved, but that transplant patient also needs to be. Early on after transplant, when patients are experiencing pain and they're getting used to a number of new medications, the needs, I think, for the support person certainly are greater at that time. And then hopefully, as we continue to follow patients when they come back for follow-up visits, we can focus more too on are they gaining more and more independence. You know, an example also I think is in the post-transplant teaching that goes on the nursing floor before patients are discharged. Again, want caregivers and support individuals there, but the patient needs to be active and involved and engaged in that process. So I think how you inform and educate patients about what is expected, what will be happening post-transplant, and that really begins in the evaluation process and continues, I think, to be reinforced with patients during the pre-transplant period. So I think it can be a little challenging balance at times of emphasizing the importance of support, at the same time encouraging a patient to master and be independent with their care also.
Thank you, Kay. My another question is, what resources does a social worker have if a patient is unable to identify a caregiver?
You know, that is a question that comes up frequently, and I think of two options that patients can explore. Obviously, sometimes we have patients that have the financial resources to hire private duty. So I have a couple of private duty agencies that patients can go to, request chore workers that we educate and train about transplant, and they become a part of that patient's life. They're devoting a lot of time, a lot of energy to kind of be in a pretty significant role. It's very expensive, but it can be an option for some families. We're also as a program, and I'm sure other programs may feel very differently, of developing a schedule of caregivers. So a family may not have one particular person, but they might have a couple of individuals, or say 3 children, that could each do a month at a time. So we're flexible in those situations as long as those caregivers are meeting criteria, and I, as a social worker, have had some dialogue with them to explain the role and to talk about their responsibilities beyond the hospitalization, and to do some education about the transplant process.
Thank you, Rebecca. One more question from Megan. I don't intend to have children, so I would not have that type of support if I needed a transplant. Has any agency considered a buddy system or some support system that would put recipients in contact with non-related to serve as their support person? Blair?
Yeah, this is an interesting idea. I don't believe we've ever had anybody present that idea in the past. We do have a lot of patients who maybe are ways out of transplant, months and years, and want to give back in some way, share their experience, volunteer, be a mentor. I haven't considered the buddy system in that way. I guess my question would be with how often how would they be able to stay overnight? Would that be, I don't know, I guess I would have a lot of questions. There are a lot of details I would want to iron out with that, but that's not a bad idea, especially if maybe they had become friends through the mentor system in some way, and a lot of patients do that without our knowledge or without us intervening as the transplant team, but if we've connected them as mentors or they've met at the support group, they share their information and they reach out on social media to each other and get together. So I don't think that's a bad idea at all. I appreciate you mentioning that, Megan.
I think just add briefly, I have to kind of piggyback on what. Go ahead, Dave.
Oh, I'm sorry, Rebecca. I was just going to make a comment from what you said also. You know, I think, and the question's on me, I think oftentimes people when you first talk with them about support, kind of they have a reaction, oh, there isn't anybody who could help me like that. And sometimes I think if you just take some time and present possible different people that they maybe hadn't thought of. Are there individuals, you know, in other community contexts, a past coworker, and maybe again these support people would have different tasks or roles they would play. But I think sometimes just helping someone, asking them to think a little beyond the immediate system that comes to mind with them and think outside of the box a little bit of what other individuals are a part of their life that may be someone that would be able to help them, maybe not the same as a daughter who could stay with them at nighttime, but help with other care needs that they may have. So I find that often if I just sit and kind of ask different questions about people they interact with in their day, it's really amazing often what other significant people in their life individuals are able to identify.
All right, Rebecca, I have one more question. Do patients qualify for SNFs, skilled nursing facility placement, for post-transplant care?
So a lot of patients will come into an evaluation thinking they can just go to a skilled nursing facility afterwards to recover, and typically they do not because they're much more progressed than meeting the need for skilled nursing in a facility under Medicare guidelines. So we really discourage that, and we discourage that also because of the significant immunosuppression and being in a facility with other patients who have typically just been discharged from a hospital. So not typically. Now, they would qualify if we see some other core rehab diagnosis, such as somebody who had a stroke during their transplant. Then we could look at options like acute rehab or skilled nursing. It's always a way of trying to be creative and really probing people. We had a sister of Notre Dame that we transplanted, and she recovered at the mother house, literally had a bunch of nuns taking care of her. And, of course, she just thought that was the ideal way to recover and wanted to have all of our patients go through the convent. So you just have to think about what's in your community, what resources you have. And I agree with Blair. A lot of times those informal connections that patients and caregivers make are so incredibly valuable, just to know that there's other people in the same situation that they are that they can talk to.
Thank you, Rebecca. One more question about the caregiver. How does the program address literacy of a caregiver, and what services might be available?
Could you repeat the question one more time? I'm sorry, Sunmi.
Sure. So how does the program address literacy of the caregiver? How the caregiver have a good understanding about the medical terms and medical condition and treatment plan. And in that case, what services might be available at the hospital level or any transplant center level?
In questions about literacy, which I think this was regarding, hopefully we all have programs where we have, first of all, part of the psychosocial assessment is to do our best to get an understanding of what the literacy, what level of literacy does an individual have, which we understand, which we know is certainly more than asking one or two questions. And so really an in-depth exploration of that, and then being aware of that potential challenge in advance, so that efforts are made pre-transplant, efforts are certainly made post-transplant. Our pharmacologist we have that works with us, who does one-on-one teaching after transplant, will use different, perhaps more with photographs. And there are so many great programs available to help individuals who may need to look at other ways of trying to learn this information. We have certainly transplanted many patients who have very limited, if any, reading and writing skills, and it has been amazing to see, with a concerted effort, with a team effort, how they can become independent functioning individuals. We recently transplanted a woman who had a past neurological event. She had neuropsychological testing done. That testing was extremely helpful to identify areas of deficit. She had shown at home that she had the ability to be independent with care, but that neuropsychological evaluation also helped give us specific steps and points about ways of working with her and how to help her learn information. But we all worked together on it. The dietitian who worked with her, the pharmacologist, the bedside nurse, myself, our nurse practitioners, and she was discharged very successfully with a good, intact support system, and that was key for this woman. Her two daughters lived nearby and were involved throughout the process. That was so important in how she was first of all recommended for transplant. And as the one slide I mentioned talked about, that support system helped mitigate some of the other concerns we had about the patient. So with their support, our adaptation of teaching, she left with an intact, available support system and left really quite independent with care.
I'll just add on a little bit. One of the really big pieces of our program here at Barnes-Jewish is our mentor program. So we have a very active group of patients who have been transplanted that are now hospital volunteers. So they do a lot of one-on-one with patients and caregivers. They take them on tours. They show them where to go when they're called in for transplant. They show them where certain offices and areas of appointments are. They sit down with them and talk with them about how to manage their care. So we do a lot of one-on-one with various professionals and mentors, as well as a lot of teach-backs also.
Thank you, Kay and Rebecca. As we are wrapping up here, Deanna, do you want to take it from here?
Yes, thank you, Sunmi. On behalf of the Alliance, we'd just like to extend our sincere thanks once again to all of our speakers, Kay, Rebecca, and Blair, as well as Sunmi for sharing your time and expertise on this topic. And to all of our participants, as always, we thank you for your time and for joining us today, and we wish you a wonderful rest of your day.